So we're going to get started. Hello and welcome to our session, Joining Forces, Creating a Regional Pediatric Emergency Medicine Collaborative in Northern California. We are so happy to be here with you this morning or recorded virtually later to discuss this really special and highly productive group that we've had for 3 years. We're going to be sharing details with you in the hopes that you and your colleagues will be able to implement something similar in your region. We're going to share with you how our group came to be, the types of projects that we've tackled, and lessons we've learned along the way. But first, we have no conflicts of interest. Now, onto a brief introduction of who we are. All of us are pediatric emergency physician or pediatric emergency medicine, PEM physicians who work out of 4 institutions: Stanford University, UC Davis, and UCSF Benioff Children's Hospitals, Oakland and San Francisco. We also have a smattering of community PEM physicians and fellows from all of our programs. For a few more details on who we actually are, my name is Dinah Wallen, and I work at UCSF Benioff Children's Hospital, San Francisco, and San Francisco General Hospital. I'm the director of didactics for our EM residency and also assistant medical director of PEM at the General. I completed my EM residency here at UCSF San Francisco General and my PEM fellowship at UT Austin Dell Children's Medical Center. My main areas of interest are pediatrics, of course, medical education, bioethics, and diversity, equity, and inclusion in health. I'm also, Dr. Moon Lee will join us after she finishes moderating an abstract presentation session this morning. Moon is a pediatric emergency medicine physician and emergency medicine physician at Stanford. Her primary interests are quality improvement, patient safety, stimulation, improving care, and community EDs. Moon completed residency at UC Davis and fellowship at Hasbro Children's Brown University. Prior to joining the Stanford team, she was on faculty at Tufts. Now on to Dr. Magana.
I'm Julia Magana. I'm pediatric emergency medicine here at UC Davis, and my primary interests are child abuse evaluation, and also I enjoy anything that has to do with that, advocating for victims of human trafficking, trauma-informed care, all of those pieces and the components that go along with that. And I am a podcast host of EM Pulse podcast, and that is a fun part of my career. All right, on to you, Sarah.
Hi, I'm Sarah Leibovich. I finished my fellowship in Peds EM at UCSF Benioff Children's Hospital, Oakland, which is where I still practice. In terms of my academic interests, I'm interested in medical education. I'm our medical student clerkship director for the ED. I'm also interested in child sexual abuse evaluation and sickle cell disease. And I'll toss it now to Emily.
Hi, I'm Emily Andrada. I am a pediatric emergency medicine physician at UC Davis. I trained at UC Davis and then did fellowship at Hasbro at Brown University as well. My primary interests are with regard to medical education, are educational technology in graduate medical education, and effective learning strategies. Andrea.
Hi guys, my name is Andrea Fang. I am an emergency and pediatric emergency physician at Stanford University, where I also run the fellowship, and I trained at Harvard, UCLA in both residency and fellowship. And my interests obviously are in peds emergency medicine education, and also women's issues in academic emergency medicine.
Awesome. Thank you so much, Andrea. So now you have an idea of who we are. And as you can see, we have a really wide breadth of interests, areas of expertise, passions, and this diversity really gives us strength. So now we're going to talk about the Northern California PEM Collaborative itself and how it came to be. Moon and I met at the 2018 SAEM Consensus Conference, which, as many of you may recall, centered around pediatric emergency medicine. We realized We're so close geographically, and why don't we know each other, first of all? And then we thought, wouldn't it be great to have a collaboration between all of the PEM groups in Northern California to focus on all facets of a career in pediatric emergency medicine, including education, research, and clinical care? Moon knew people at UC Davis, where she did residency. She had worked part-time at UCSF, Benioff Children's Oakland, and now she worked at Stanford. So she was invaluable in building the network. I knew people at my institution, and I knew Moon. So after SAEM, Moon and Julia had a conference call. Keep in mind, this is pre-Zoom era, with Dr. Paul Ishamin in San Diego to talk about the conference Rady has each year for EM residencies in the area, to get some more information on that conference, as well as their multi-institutional collaboration and how they were able to get that done. Our group met for the first time in July 2018 over Zoom, before Zoom was a thing. And in that first meeting, we came up with several plans already: a boot camp for our PEM fellows, a faculty social event, and a PEM conference day for senior EM residents in the region. There were so many fun ideas that came out of that very first meeting. But why did we even join forces in the first place? Was this collaboration even necessary? Julia, tell us.
All right. Well, I think it's necessary for a bucket full of reasons. First and foremost, we all know that children are seen predominantly in community emergency departments. Approximately 70 to 80%, 90%, depending on what study you're looking at, of children with acute injuries and illnesses are actually seen in general emergency medicine physicians in general community emergency departments, and not in PEM. And so we need to really invest in our residents, and only 13% of their academic time is dedicated to PEM education, whereas 20 to 30% of their practice is. So there's this real gap there. And we wanted to make sure that we were optimizing that time together as a community. We had resources from other places, and we didn't want to duplicate that. We wanted to build on each other so that we could optimize that time, since they are the ones taking care of our kids out in the world. So we have this important job of educating them. So education and helping improve care of children of Northern California was our primary drive. And then we also have, we're inside of a geographical area, and there's small pockets of us in this geographical area, but they're fairly small. Em and I hang out a lot together. Nate and I hang out a lot together. But, we needed to cross-pollinate a little bit. And because we're small little pockets, we were able to join together and make a fairly large-sized pocket, and share and support each other and learn from each other in a unique way. So I think that collegiality and what I call cross-pollination, I think is another really big driver there. And then also, as far as our own clinical practice in supporting each other and having that friendship, we were then able to ask clinical questions of each other and kind of share within a region as we, went through COVID together, or mental health crises, different things like that. We're able to share and help find resources. And so we felt that there was a need for all of this. Moon is not here. Dinah.
Yeah, so it's me. So thank you so much, Julia. I think that you really emphasized that there was a void, right? There was something that our group needed to fill. And so then we got to the point of, how did we actually make this happen? And this is really, I think, the key driver of this talk, is to share with all of you how we operationalized this and really made it work. So first of all, to recruit members, we recruited by word of mouth. So Moon spoke with her contacts at Davis and at BCH Oakland, and then she recruited internally. Hello, Andrea. I then peer pressured some friends at BCH San Francisco, and then we had our group. So as far as our structure goes, this, I think, is something that is unique and what has worked really, really well for us and made our group successful. So at the time of development of the collaborative, Moon was taking a leadership course, and she had learned a bunch of strategies for best structuring tele or virtual meetings. So if you could remember, I think it's really hard for all of us to remove ourselves from the current time, but this was pre-COVID, which meant that not many people were using Zoom on a regular basis. Many of us didn't even have Zoom accounts at that time. So first of all, we created the collaborative to be a flat structure without any hierarchy. We figured since everybody is volunteering their time, who would want to volunteer more time for free? So we decided that we would just sort of spread the leadership and spread the work out equally. We center our meeting structure around multiple recommendations from Moon's course. So one, we decided on short meetings, 30 minutes, to maximize productivity and efficiency. We meet on a standing date and time, the third Thursday of the month from 12 to 12:30 p.m. This made regular participation in the collaborative super easy. Two, we start each meeting with an icebreaker. We usually do an either or question, such as burrito or taco and why, or something specific. What appliance could you never live without? This goes surprisingly quickly, and it helps us rapidly connect with each other and really become present. Plus, you learn things about other people that you would have never elicited otherwise. Three, we all keep our video on if possible. And this was particularly important because at the beginning, many of us had never actually met face to face. And so it was nice to be able to correlate a face with the content being spoken. Four, we rotate who's leading the meeting and taking minutes. This gets more people engaged in the process of the meeting itself and also ensures that all of us understand what's going on with all of the projects. Oop, I just lost my screen. There we go. At the close of each meeting, we elicit volunteers to lead the next meeting. And then that leader will send out an agenda. They will facilitate the meeting. They will take notes and then send out the minutes. And to that topic, 5, we have a shared Google Drive folder for all of our agendas, minutes, and other relevant content so that everyone can access everything whenever they need it. Okay, so now you have an idea sort of our origin story and how we like to run things. So let's shift into what we've actually done. We've collaborated on numerous projects in the 3 years since we were formed. So first of all, as Julia mentioned, clinical practice of PEM. We discuss clinical practice all the time. And sometimes it's just going to be simple clinical queries like, do emergency physicians at your site need to maintain a fluoro license to use the C-arm for reductions? I also personally relied on the group a lot when I was tasked with developing an evidence-based pathway for pediatric blunt torso trauma. With just one email, I was able to query not only my colleagues' sites in the region, but also all of the places that they had trained for residency and for fellowship. Having multiple examples of how other institutions do this helped me sell my pathway to our team back at home. As Julia mentioned also, when the COVID-19 pandemic hit, we really leaned on each other a lot, asking about testing and treatment protocols, algorithms for airways, and evaluating for MISC, and even how to support each other through this really rough time. I myself actually got COVID very early on in March 2020, and Moon and I co-authored this post on academic life and emergency medicine on how to best support your sick colleagues. No one really knew what we were doing at that time, and we worked together to be able to disseminate that information. Not all of our work is purely clinical, though. Emily and Sarah, you want to talk about the fun stuff we do?
Yeah, so part of our mission has always been to facilitate sort of hybrid learning and social events across the Bay. We have mainly during pre-pandemic met in Oakland, only because that is the central location to all of our hospitals. But we've done several events. One that I think really stood out was our POCUS workshop that we hosted at Children's Hospital Oakland, of course, with a lot of help from our colleagues across the Bay and elsewhere, where we had instructors, experts in POCUS from several institutions teaching and sort of reviewing for us and the fellows, FAST, pericardiocentesis, and femoral nerve blocks on models and actual like children and volunteers. And then a really fun social event that we always try and pair our educational things with, this time at a Mexican restaurant right by the hospital. I don't think we knew at the time that, well, we definitely know at the time that was going to be our last in-person social event before the great disaster 2020. And so we were looking to figure out what we could do to maintain sort of cohesion between all the institutions back in the spring. So we put together a really fun sort of Zoom interaction regarding difficult conversations, where we asked everybody, any volunteer from anywhere at all our sites, to come and give a 5-minute talk on their subject of choice regarding having difficult conversations with families, with colleagues, with friends. Talked about trauma-informed care, and sort of diversity, equity, inclusion in terms of having difficult conversations with families. And we also wanted to pair that with a social activity as we could. So we asked people to dress as their favorite movie character, and then everyone had to guess what it was, which had varied participation in, but that was really fun as well. And those were two of the events that stood out for me. And then of course, PEM Ed Camp.
So PEM Ed Camp was planned by the groups from Stanford and UC Davis. And what we did was we planned a dinner at a really beautiful restaurant in Oakland. And at the same time, over the meal, ran something called PEM Ed Camp. And Ed Camp is an idea that was first started with a lot of K-12 educators. Actually, the first one was held in Philadelphia back in the 1990s, where there was really a rebellion amongst these K-12 educators, where they were sort of rebelling against the idea of the administrators deciding what sort of professional development they should have. They wanted to have a much bigger choice in what they learned. They knew that they were all content experts in what they were doing, and they really just wanted to have a venue to share ideas and have it be affordable, in fact, free. And so they came up with this idea of Ed Camp, where they basically gathered at the school on a Saturday morning. They put up Post-its on things that they wanted to learn or things that they could teach. They spent a little time sort of collating those things and then assigning a specific topic to a room. And then people that either wanted to teach that topic or talk about that topic, they just went to those rooms and talked, just sort of had a discussion amongst themselves. And so using that framework, we basically asked everybody as they were coming to Ed Camp just to think of one clinical pearl or one teaching strategy that they just wanted to share with the group. And so over the course of the dinner, we just took turns getting up in front of the group and just sharing that one clinical pearl, one teaching strategy that we were very comfortable with. So it really required very little preparation. But in the end, what we were able to do is crowdsource a ton of resources on all kinds of medical educational topics. So for those of you that are watching later, you can scan this QR code and get to the entire collated list. But all around the photo, you can see just how varied the topics were and all the different sources that these ideas came from. Excluding the dinner, which was lovely, it was all these educational pieces were essentially free. We didn't have to pay for a speaker. We just were our own speakers and our own source of professional development. All right, and then now we're going to switch over to research.
Okay, one of the first research questions that we asked was, well, first of all, we asked, can we do this? As a team, we have access to these hospitals inside of a region. Can we leverage that to be able to understand how how providers practice, and is there an area that we can show improvement in? And the first question that we asked was, okay, let's talk about skull fractures in young kids. There seems to be quite a bit of variability among sites as far as are we getting a skeletal survey? Do you take this seriously? Do you call CPS? When do you worry? When do you not? And most importantly, what are some of those barriers to doing further workup for child abuse? So we crafted a survey that was put through Qualtrics, and this is a screenshot so you can kind of see what it is. And we received IRB approval at each of our separate sites. And we sent this out, an electronic survey, and to 135 PEM and EM physicians at 5 sites. We had about a 60% response rate. And about 88% of people said that they would get a skeletal survey on a 6-month-old without a trauma story. So that's a good spot to start for sure. But that means that there's still a fairly large percentage of people who are not getting a skeletal survey in kids that are at the highest risk, especially without a trauma story. So we started to ask them about what are the barriers to obtaining skeletal surveys, and we found that radiology availability, concerns about parents not wanting to get skeletal surveys were some of the biggest ones, and then just the skeletal survey not being available 24/7 was a very large barrier as well. So this allows us to do some practice improvement at our own site, and it is also a foundation for future multi-center study looking at actual charts and what is practice, not just what do they think that they're practicing. So it was kind of a cool exercise to do this between all of these different sites. All right, Andrea.
Yeah, and so for me as the fellowship director at Stanford, one of the best things to come out of our collaborative was during our very first meeting, we were brainstorming of ways we could work together. And UCSF and Oakland have a fellowship, and we're like, wouldn't it be great if we could, synergize and use the fact that fellowships tend to be smaller and help like get together and do orientation and education for all our fellows together. And since then, this has been something that has been 3 years now, where the UCSF and Stanford, UCSF CHO and Stanford fellows meet every year at the beginning of the summer when they first arrive. And we do 3 days, one at each site, which I think is also really nice in building relationships and collaboration. And each day is a little bit of a different theme. So at Stanford, pre-COVID, we would do the simulation day and go through cases, but there will also be wonderful icebreakers that would kind of be fun and camaraderie building. And then at UCSF 2 years ago, they did like ultrasound and like sedation. And then at Oakland, the last day, we did a bit of a procedural day because these are, most of these people are pediatricians. So it was just a wonderful opportunity to get together, have different faculty interact as well, and build our own network amongst each other, not just the people in this room, and for the fellows to get to know each other. And we would also do things like job career searching advice and give people different perspectives. So I loved it, and I'm so grateful for this group for making it for being the NIDA for making it happen. And the other thing we did, which I think everyone had the desire to do, but we just couldn't figure out how to get through it, was we really wanted to educate our emergency medicine residents and how to give great pediatric emergency care. And there are only so many faculty at every institution, but the ability to get everyone together and educate together seemed like this wonderful dream we could have. But it also, to me personally, seemed like a huge undertaking. But because of this group, and before COVID, we had plans to get our 4 residencies together on one day and bring all the regional PEM expertise we could together and focus on a theme. And last year the idea was to do it, and we canceled because literally it was going to be in April, which came right aligned with the shelter in place. But we were going to teach about neonatal education. And then after a year, we said, okay, let's do it again, but in a virtual format now that we were all kind of familiar of how to do it. And this is just a snapshot of everyone who was participating. We had almost 100 participants, like resident and faculty. And I'm going to pass it on to Emily to talk about like the theme and how we were able to execute education for so many people in such what I consider to be a really effective manner.
All right. So the structure of the educational day was really based on a couple of ideas. One, we wanted to figure out why would we bring together all the senior EM residents from 4 different programs? Like, what was the purpose of that? Because we all probably could have taught them the same content in our own shops, but what was the purpose, the overlying benefit of bringing them all together? And so what we landed on was this idea of cooperative learning. So there are a multitude of cooperative learning strategies out there. We happened to pick one called the Jigsaw method, and we wondered if the effect on graduate medical education and learners in GME would demonstrate the same benefits that it showed in younger learners, so elementary school, high school, and college. And those benefits really looked like an increasing amount of autonomy, much more motivation in self-learning, and an increasing connection to those around them, especially connecting to folks that are really different from you. So in our case, folks that are from a different program. So we really thought that would fit well with an educational day. And as Andrea described, it actually transitioned well over Zoom. It actually made it easier to have this day because it eliminated the need to physically be in one place. And if you all know what traffic looks like in the Bay Area, it is a hard stop. It's an overnight trip to the Bay Area sometimes. So the structure of the day that we landed on was, if you're following along on the slide on the left side, there was a large group lecture. And in the morning, we started with Dr. Cooperman and Dr. Magana talking about fever evaluations in kids that are 1 to 2 months of age and the application of the PCAR and infant fever rule. And then what we did with the 4 institutions, the learners from the 4 institutions, was to build mixed teams. So ahead of time, we assigned teams that consisted of learners from every single institution. So they were sort of put into a breakout room and kind of forced into a bit of a situation where they had to be able to get to know each other and then strategize amongst themselves on how they were going to attack the mission of learning all the 5 topics that we offered for neonatal emergencies: neuro, GI, cardiac, respiratory, and shock. So their team had to make sure they covered all of those topics, assign someone to each of those. That one person who was assigned to that topic needed to become expert in that topic. So this is where our faculty and our PEM fellows came in, which is that they ran each of these sessions, taught the learners, usually one from each group, how to know all the things that they needed to know about that topic and become expert. Those learners in turn needed to recognize that they were going to have to then teach their peers. So after the marketplace, that 3rd block in the middle, where they rotated through each of these at least 2 topics, 2 of the 5 topics, they returned to their mixed teams in this 4th block to teach their team. So this involved quite a bit of peer teaching, but also really encouraged a significant amount of learner interdependence, right? They were dependent on each other to then succeed as they returned to the large group at the end, where they then participated in a team quiz. So we tried to give them a little bit of motivation, like, hey, we're going to recognize the team that has the most number of learners in the top 20, and certainly the person that finished first. But there's a little bit of competition and motivation in there. But what this really tried to encourage was learner independence, peer teaching, without, in the absence of, what we are used to, which is like teacher-led sessions. So this cooperative learning day, we actually also it wasn't only an education day, but it ended up being a research day where we actually surveyed the learners before and after on knowledge-based questions, and then also surveyed them on social connection and how much this particular experience either improved that or didn't improve that. And we are looking forward to seeing the results of that. And hopefully we can share that with you in the future, potentially in a publication.
Thank you so much, Emily. So I'm hopeful that all of you are able to see we have accomplished a really wide breadth of projects. And while it might seem like it's a lot of work, it honestly has not felt that way. Meeting with my colleagues with the collaborative, it's so fun and invigorating and stimulating, and all of us learn from and with each other so much. So the work doesn't feel as difficult when you're collaborating with friends. What's really important to understand is PEM is already a very small community. And not only do all of us faculty already practice in the same region, a lot of the graduating fellows and graduating emergency medicine residents who are going to go on to practice in the community and not do any sort of fellowship, we're all going to be practicing together in the same region for a long time, potentially decades or complete careers. And so all of this networking and socializing and connecting and learning critical clinical processes together really has a lot of potential to improve the quality of care that we deliver to children in a very large region. So now we're actually going to transition into a slightly more reflective portion where we really just ponder the last 3 years and offer you some practical wisdom on what we think went really well about the collaborative, what are some of our strengths, what might we do differently if we could have done things over again? And what little tidbits of advice will we have to offer to anybody considering doing something similar in their region? So, Andrea, would you like to kick us off on this reflection?
Yeah, I think big picture wise, I always wonder like, why were we able to like keep going on this and what made this so successful? And I'm actually so impressed with what we've been able to accomplish since this started. And I think it is you really need invested people from any institution, from all the institutions. And when I say invested, I think people need to have emotional buy-in. And by what I mean by that is you need people who really believe in the cause. And so it doesn't have to be a pediatric emergency medicine. We could be successful in any other, you could be successful in any other field that said X collaborative, but everyone needs to have some buy in the cause. And I think for all of us, we all automatically had this desire to, I would say, to improve emergency care of children within our region by any means that was within our power and our skill set and influence. And since we all really wanted to improve the care of children and share that, we all kind of committed to this mission. But I'm curious, because Moon, you were one of like our founders and one of the first people to get this started. What was the thing, one of the main thing or things that you had to focus on to make sure like this little flicker of light or flame that now has become a fire, but at that time it was just a flame, how did you make sure it didn't extinguish?
That's a really good question, Andrea. I was thinking, you're right. One thing that was really important was that we all have a common goal of improving care for children in this area. But I think that the thing that I focused on the most was probably team building. We had 4 different institutions. Some people knew each other, some people didn't know each other at all. And I think that was the most important thing, was to make sure that we were accountable to each other, that we build good relationships, which is why we started every meeting with an icebreaker so that we really could get to know each other. And I think it was also very helpful to focus on making sure we distributed the work pretty equally so that not one person felt like they were carrying the burden and that they were doing all of the work. Otherwise, that's not a really sustainable approach. And so sometimes I think about how I didn't even know Julia when we first started this. Like I really had even met her, and now like I really consider her to be one of my friends. And so I think that's just really important to focus on. Team building relationships is like really the key to creating a sustainable project.
Andrea, would you actually be willing to share with us like what you were talking about before when you were reflecting on our different strengths? Because I think that really names a lot of it kind of melds those two purposes together, the socializing that Moon talked about, as well as accomplishing our actual goals.
Yeah, it was interesting because as we started having ideas and little projects and moving forward, you kind of realize everyone had a different strength, and we were able to actually complete projects because like we were saying, we didn't have a burden. So sometimes we would just like pass the ball or baton on to different people at different times, so it didn't feel so overwhelming. So like when I think about like just recently, because we finished our education day for all the emergency medicine residents, I thought, Moon was really organized. Like we couldn't have done this if she hadn't like kind of kept us focused and gotten us together. But like Emily has this amazing vision as an educator that if you are not a creative person, like sometimes I can't come up with these ideas, but when I hear like that's a great idea. So her just vision and ingeniousness as like an educator, I found so inspiring. And then I consider like myself like a good worker bee. And like I feel like Sarah and I are just people you want on the boat. You want us like, we'll keep rowing with you, just tell us where to go. We're happy to support you. And we really like the vision. And Julia and Diane are just really engaging personalities and orators, and I consider them to be great like educators as well. So because of like all these little things coming together, I feel like we were able to accomplish so much in terms of our research projects, our submission for our scholarly work, that all really kind of supports each other. And the other thing I would add is we're all in academic medicine right now, and there's something to be said for promotion and recognition. And I find from this opportunity, we've been able to elevate each other, whether it's inviting people to lecture to our own institutions. I invited Diana because she's really close and so engaging, or, these things that we're doing that now we can talk about when we're trying to promote ourselves.
Thank you, Andrea. Go ahead, Moon.
Oh, I was just going to say, I really also really enjoyed our camaraderie during COVID. It was just so nice to hear, what are you doing at your institution? How are you dealing with X, Y, or Z problem or issue during COVID? And it was just really nice to know that you are not alone and that you have this whole network of people that you can ask advice to, like, how long are you wearing your N95? Do you wear it all the time, only on certain people? And are you seeing any COVID cases in children? That was a really big deal at the beginning, that we didn't really have that many cases, and then slowly it ramped up. And so I just really appreciated having everyone as a resource, which I think sometimes we're so focused on our goals that we forget that this is like a supportive network of people. And I've said this in the past before, but PEM as a general group is just a really great group of people to work with. Everyone's very enthusiastic, very motivated, and they just have great personalities. So I just would like to put that out there.
I've also just really enjoyed the fact that we're able to introduce each other in a more like organic way to our own colleagues at our institutions. Like, at these social events, I've met so many people from especially Stanford and Davis that I never would have ever, that aren't even part of our groups, but that probably wouldn't have come or wouldn't have been as open or genuine in a more formal setting that was organized by our institutions themselves. So I've enjoyed that.
Julia and Emily, what are some thoughts that y'all have about what's worked well, what you might do differently, or advice for people if they are considering doing this in their own region?
Yeah, I would just say, as we discussed earlier, that I wish we had started this earlier. I've been at UC Davis since 2003, and gosh, in my head, I'm thinking, how different the trajectory of my just my development as an academician and a faculty person would have been exponential. I think if something like this if I had been part of something like this earlier on, but I'm glad it has started and it is present now. And I would just emphasize, like, there's such a ripple effect to this kind of collaboration amongst institutions. Like, it really is just this huge exponential increase in the ability to just talk about projects, but also to get projects moving and to get big things done with with so many hands to help with the work. That really cannot be underestimated.
Yeah, I think it's higher impact with more hands to help with the lift. So it's overall a win-win. I would say one of the key pieces that we have found is having at least 2 people for buy-in at each institution. I mean, you could do it with one, but it's much easier if I'm like, hey, Em, are you doing this? Am I doing that? Or I'm not able to be there. Can you update me on that piece of it? Because none of us are being paid to be here, right? And so if my schedule doesn't align, usually Emily's can, or vice versa. And so having a few people that can plug in and be there with our weird emergency medicine schedule, I think is a helpful component.
Yeah, because if you're working, I'm not.
Right. Yes, that's true. For us, that is true. Also, then we're able to send out personal invites. While many people at UC Davis remember Moon, a lot of them don't, right? But they all know Emily Andrada. And so when she sends out an invite, there's power to engage with that versus just a random invite from somebody from another institution. So I think having buy-in at each institution and more than one person is just a really key piece of this.
Thank you so much for sharing that. Oh yeah, go ahead, Emily.
So also, I would just say what has been key for us is to have the buy-in of our department chair, and not just because he's in the room, but truly like from a financial standpoint for some of these faculty developments, like that really made those things happen, and made them really enjoyable events. And and that kind of support is really invaluable, to have had the support of our department chair for this work and for these, and financially for these events.
Yeah, because while the teaching part of it was, free, being in a beautiful setting, both of the times that we've got together in person, in a beautiful setting with good food and t-shirts, that does not come for free. And so having that makes that, that little bit of swag, that little bit of like being on the ocean side at Oakland, being outdoors in a beautiful setting with your colleagues, that just like takes it to the next level. So while a lot of this is happening for free, there is, having a little bit of money to pay for food at the conferences or whatever, the room, that is helpful.
I like that idea of taking it to the next level that you say, because people watching this might be wondering, like, why do this, right? Why add another meeting to my month? Why make more work? Because yes, it is more work to do things with other people than it is to just like forge through and do it on your own. But this takes us to the next level, right? Like this has elevated us, our work, our clinical care, just to a completely different place because we're bringing in so many strengths and talents from other people. Did any of you have a last comment before I wrap us up? Okay, perfect. So, I want to thank all of you out there for sharing your morning with us or for watching this video later on. And we really, really hope that now you're inspired to form a regional collaborative near you. And I don't want to limit y'all to PEM. So whether your niche is PEM or ultrasound, medical education, global health, really anything else, you can form a meaningful, powerful, and productive collaborative. I cannot overemphasize how much the collaborative has helped my career and my personal well-being. So not only have all of us gained numerous line items on our CVs from the projects that we've done together, we've all helped each other out a lot personally. And I genuinely believe that we have improved and are continuously improving the quality of emergency care delivered to children in Northern California with our work. Through the NorCal PEM Collaborative, we've all gained mentors, project partners, and friends, and we all cannot wait to see what the next 3 years bring. So thank you all so much for listening to us, and I am going to reshare here. Sorry about that. I have our email addresses. If you have any questions, since we didn't have an opportunity for a Q&A, please feel free to reach out to any of us with questions, comments, concerns. If you want to hear a little bit more detail about any of the things that we talked about today, all of us are very, very happy to engage with you. So thank you again so much. And I hope everybody has a wonderful rest of the day.